and gentlemen. It is with joy and pleasure that I welcome you all this morning to the very first pre-Congress session that we have organized through the Sri Lanka College of Specialist Family Physicians. As most of you may already know, this is the first day of activities in a series of events that would be running through 3 days, organized in parallel with the scientific sessions that are scheduled to be held on Saturday, the 25th of November 2023. Whilst we pay tribute to the founding president and the members of our previous association, this year, amidst a lot of challenges, we have been able to evolve into an academic college under the current leadership. Our college, though being very young, has been immensely blessed to have a membership of diverse talents and strengths. Over the last few weeks, we have seen the entire team come together, working as one, and selflessly dedicating their time and efforts to make these events come to life and a success. Any great team is a reflection of great leadership. Likewise, we have been very fortunate to have the guidance and the leadership of our president of the Sri Lanka College of Specialist Family Physicians. Let me call upon Dr. Malkanthi Galhena, President of Sri Lanka College of Specialist Family Physicians, to address you this morning.
Good morning to all of you today, and I warmly welcome the speaker already arrived, Professor Lakmali as Amarasi, and all of the council members, including our founder president of our Association of Sri Lanka Specialist Family Physicians. So today is a very important day for us. This is our first inauguration. In parallel to the inauguration, we are going to have our pre-Congress session, scientific session today at Lanka Hospital. So thank you very much for all of you. And we being as the specialist family physicians, as the college, we have understood the commitments to serve our people better, to have the patient-centered, the transformation of the present management towards the patient-centered management in recent future. So our strength is our members. We all are united and committed to come to achieve that common goal. So thank you very much for giving me this opportunity to speak to you, and I wish you all the very best for your future endeavors. Thank you very much.
Although we have quite a few seats left to be filled up, I think it's important that we start on time as we have a busy schedule lined up for the rest of the day. So I would like to call upon Dr. Malkanthi Galhena, President, Sri Lanka College of Specialist Family Physicians, and Dr. Niroshini De Silva, Consultant Family Physician from Base Hospital Maravilla, to chair the first session of the day. And it is titled Puzzle Out Breathing, Enlightening Lung Functions. Over to you, chairpersons, to introduce the speaker and proceed with the presentation.
Today, I'm going to invite to our first speaker of the pre-Congress session of Sri Lanka College of Specialist Family Physician. Our speaker is Professor Lakmali Amarasi. She is the professor in physiology at the Department of Physiology in Faculty of Medicine, Colombo. She is an honorary visiting clinical physiologist at the Central Chest Clinic, Colombo, Lanka Hospital and King's Hospital. She has over 20 years of experience as a clinician and has served as a trainer, examiner, a supervisor, and a curriculum developer in both undergraduate and postgraduate training. She has numerous publications in national and international journals and has research interests, especially on respiratory, gastrointestinal physiology, chronic respiratory disease, and extraesophageal manifestations of the gastroesophageal reflux. And furthermore, she is our own product of our Sri Lanka. She is graduated from University of Kelaniya. She has been awarded the PhD by the University of Kelaniya as well. So I would like to invite Professor Lakmali Amarasi to the stage to deliver your lecture. Thank you.
Good morning, everyone. Thank you, Dr. Galhena, for that kind introduction. Today I'll be talking to you. My title is Puzzle Out Breathing, Enlightening Lung Functions, right? So basically, in my talk, what I'm going to be doing is introduce you to the various types of lung function tests that are available, but go into a little bit more detail on spirometry, which is like the most common lung function test that is carried out in Sri Lanka today, right? Okay. So, now, regarding lung function, one thing you need to remember is that it's a very effort-dependent and very technique-dependent technique. Like, so if the patient doesn't perform the test well, and if the technicians are not skilled enough to get the best out of the patient, then there is going to be a problem with the results. Because anyone just blowing into a machine, you can get a set of results, but that doesn't mean it's proper results, right? So because of that, it's very important that technical standards are maintained when lung function tests are performed. So the details that I'm going to talk about today is based on the recent standardization of spirometry 2019 update, as well as the ERS ATS technical standards, right? So I have sent these references across. If anyone wants, they can get them. Okay, right. So now the question comes, why test lung function, right? So there's a large list of why we should test. Well, one of the things is to diagnose conditions, right? It can be a respiratory condition, or sometimes it can be another disease where the respiratory system is affected, right? So for that, we use lung function, and it's not just to diagnose, but also to see the severity of the disease, and then also to see whether the treatment is working. So to monitor the progress of the disease as well as treatment. Apart from that, lung functions are also very important in disability evaluation, especially in certain professions, right? You need to have a lung function test before you go for that profession. And also lung functions are very much used in preoperative assessment as well as for research. People, you need to lung function in various types of research, not just related to respiratory system, but in other fields as well. So I'm going to take you through the different types of lung function tests that are available, right? And I'm going to say why we do that. Now, for example, one of the main things why we do lung function tests is to assess whether there is airway obstruction. Right? So there are different tests. So the simplest test that you can do is to use a peak flow meter, right? But the thing is, in peak flow assessment, you can't diagnose airway obstruction. What you can, because basically you take a deep breath in and the patient blasts out the air, and that is actually the movement of air just from the upper part of the airways. Right? So peak flow metry can be low in people with actual obstructive airway disease, and even in patients with restriction, because they cannot take in a good amount of air and they can't exhale properly. Right? And it can also be low in poor effort. If someone doesn't perform the test low, again, you get a low peak flow rate. So therefore, it's not a good test to monitor. It's not a good test to diagnose, but it can be used in monitoring of an already diagnosed patient. Right? Then, of course, the gold standard for diagnosis of airway obstruction is spirometry. Right? So I've just showed different types of spirometers, and the advantage of spirometry over peak flow metry is that it can not only measure the airway obstruction, but it can also give us some detail about lung capacity as well. So I'll be talking about spirometry in detail. Right? Now, techniques like spirometry, it's very difficult, right? It's a very different maneuver. So sometimes patients can't perform that. And sometimes there are patients who are contraindicated. They can't perform spirometry because it involves forceful maneuvers. So in that case, there are other tests now available where we can actually measure airway resistance, which is actually a better sensitive measure of airway obstruction. Right? So some of these tests are whole body plethysmography. Then there's another test called impulse oscillometry, which can be used in children as young as 2 to 3 years. My youngest patient has been 2.5 years old, right? So impulse oscillometry. And then there's another technique called the interrupter technique. So here, you're measuring airway resistance at rest. So that's why it's a really good test where you can say whether someone has airway obstruction. Okay? Right. So just to show you how in whole body plethysmography there are different, it's like a pattern recognition. By looking at the patterns, you can figure out. I don't think this is working, but I'll just move around. I don't know if you can hear that. Yeah, so just if you just look at this, like this is changes, right? So looking at patterns, you can figure out whether someone has increased airway resistance. This is the interrupter technique where you occlude airflow for a little bit, for a moment, and then you measure the occlusion pressure. So that is called the interrupter technique. And then this is impulse oscillometry, right? Now this is available in several places in the state sector and the private sector, becoming quite popular. So the patient is put onto the mouthpiece and breathes in and out very slowly, tidal breaths, right? And can you see this box up here at the top, right? So that box is an impulse generator. So what it does is it generates impulses, and the impulses go through the mouth, through the upper airways, down to the lower airways, and then with the lung elastic recoil, it gets reflected back again. So what the machine does is, so this is what it looks like inside, right? So you have the loud, what we are measuring is the impedance to the impulses, right? So if there is any airway obstruction, you can detect. So the advantage of impulse oscillometry is you can actually see, you can actually see whether there is any resistance in the upper airways and the lower airways, right? Right, okay. I did, but it's not very clear, that's right. That's okay. Right, okay. Right, so this is, now these are the upper, you can see the upper airways and the lower airways. So when we deliver these impulses are given in different frequencies, right? So the impulses with low frequencies, they travel all the way down to the lungs. The ones with higher frequencies, they only reach somewhere around the bifurcation of the trachea, right? So looking at the parameters, so if we look at the resistance to 5 Hertz impulses, the low frequency ones, that gives an indication of total airway resistance. If you look at the 20 impulses, they only go in the upper airway. So if that is increased, we know, okay, this person has upper airway resistance. And then there's a parameter, R5 minus 20, which tells us about the peripheral airways, right? So what is normal? Generally, up to about 150% of predicted is normal, and looking at the values, you can figure out, does someone have upper airway or lower airway resistance, right? So that's another technique. Okay. So again, with these tests, it's about pattern recognition. So if you can see the top one, you can see that's what a normal impulse oscillometry looks at the bottom, and you can see that's a normal spirometry tracing. And if someone has airway obstruction, right? Right. So very basically, looking at the pattern of obstruction, the pattern of impulse and spirometry together, you can come to a very good diagnosis of what exactly your patient has, right? Okay. Do you have any questions about impulse until they get ready? No, they're ready. Right. Okay. Okay. So again, remember in impulse oscillometry, this particular test, if you have a patient who cannot go for spirometry and you are suspecting airway obstruction, you can send for impulse oscillometry. But it is not a very good test to diagnose restriction, right? You can only diagnose airway obstruction. Okay. Now, sometimes you have a patient where you suspect, okay, there is airway obstruction, but when you send them for spirometry comes back normal. And then you measure airway resistance, even that is normal. Now, this is something we commonly see in patients with asthma, because you know that asthmatics, on a good day, their lung function can be normal. Right? So, and then there are some people who are prone to asthma, but they have never manifested symptoms. But like if they have a trigger, they may get asthmatic symptoms. So in such patients, what we do is we do tests called bronchoprovocation, right? So, and they are also called challenge tests. So what you need to find out is what is the trigger for this patient? What do you suspect as a trigger? So do they think that it is an allergic reaction or something? Or could it be exercise? Because for some, the trigger for that is exercise. So once you find that out, there are different challenge tests that you can do. So one of them is if you suspect your patient is atopic and has a tendency for allergy, right? Then to get an allergic response, an asthmatic attack, you can do what is called challenge test using histamine or a substance called methacholine. And it's where you just measure spirometry. Measure spirometry first, and then what you do is, using a dosimeter, you give increasing concentrations of histamine or methacholine, and you see whether the spirometry, the response reduces. That means whether so basically you're slowly inducing an attack. So you don't wait for the full-blown attack to occur, but you look at a reduction. So we are measuring spirometry FEV1, and we see whether, there's a decline in lung function. If you give histamine to any normal person also, lung function will decline, but someone who has a tendency to asthma, right, or exercise-induced bronchospasm and so on, they will show a faster response. So this is one type of challenge test that you can do. Then cardiopulmonary exercise testing. This is the gold standard for exercise-induced shortness of breath, right? So people, shortness of breath on exertion, you're not very sure, because you know that when we exercise or when we do any activity, there are three things. One is it could be a cardiac issue, it could be a respiratory issue, or it could be at the level of the muscle, utilization of oxygen, right? So we are not very sure why your patient is short of breath. So the gold standard for that is where you get them to perform exercise and you simultaneously measure cardiac and respiratory function, right? So this is called cardiopulmonary exercise testing. But of course, this is an expensive test and it's not freely available. So if you don't have this facility, you can of course do what are called 6-minute walk test, which is the simplest walking test. And there is also the incremental shuttle test, where you measure some cardiac and respiratory parameters before and after a short walk, right? So the patient is asked to walk for 6 minutes as fast as they can, right, in a designated distance, and then you note how far they can travel. And then you also measure their saturation, their heart rate, their blood pressure, and you look at their symptoms, whether they change or not, right? So this is a simplified form of exercise test, but the gold standard is cardiopulmonary exercise testing, okay? Then you know that some patients, especially these elite athletes, they come saying that, they find it difficult to breathe when they're doing exercise, right? And that generally, like if it is not the first thing you should do is get a cardiac checkup done, and if that is normal, one of the things, and then you do a basic lung function test, and if that is also normal, one of the things it could be is because, when you exercise, especially vigorous exercise, you get patients hyperventilate, right? And when you hyperventilate, there's a large amount of air passing in and out of the airways, and the airways get cooled up. So there's a lot of osmotic changes. The cool air can trigger bronchospasm, and we call that exercise-induced bronchospasm. So for that, there is this test called eucapnic voluntary hyperventilation, where you're simulating the hyperventilation response during exercise. So you get a patient to come onto the mouthpiece and you get them to hyperventilate, right, for a time. But the thing is, with hyperventilation, we lose carbon dioxide. So with that, patients can get dizziness and peripheral vasoconstriction and, things like that. So to prevent that, what you do is, you get the patient to breathe into a gas mixture which has some carbon dioxide in it. So they won't get the side effects of hyperventilation. You get them to hyperventilate for about 6 minutes, and you measure lung function before and after. And generally, this response happens 10 to 15 minutes after. You know, sometimes it happens during exercise, then it's more likely to be an actual condition. But this exercise-induced hyperventilation bronchospasm occurs about 10 minutes later. So you need to keep on measuring the lung function for about half an hour after doing this, just to see whether there is a reduction, right? So that's another test that we can do. Then going on to further testing, like if someone has asthma, you want to know, now we start them on inhalers, and then once they become free of symptoms, you stop the inhalers. But we don't know whether actually, though their symptoms settle, we don't know whether their airway inflammation is happening in the lungs. So one way to check is you can do the fractional exhale nitric oxide level. So there's like this meter here, the patient just breathes in and out, and you capture the nitric oxide in the airways. So normal people have very little amounts, but in inflamed airways, you have higher values. So you can figure out whether there is ongoing airway inflammation in your patient, right? Okay. So that's mainly about someone who has airway obstruction, right? So how would you assess someone where you suspect there is a restriction? So there, the first test, of course, you would do is spirometry. Now, when you come to spirometry, there's a distinction you need to make between the two words, restriction and restrictive, right? Restriction means the English word, basically, they're restricted, right? Whereas restrictive means it's actual restrictive defect. That means there is either a problem in the lung parenchyma or there is an actual problem in the chest wall, so it's an actual defect. Right? Now, when someone performs spirometry, right, you know, you can measure some of these volumes, but there's one volume that you can't measure, and that is the residual volume, because spirometry involves taking a deep breath and exhaling. But we know that we can't fully exhale. There's always this amount of air called residual volume there. Right? So in spirometry, when we perform, we measure the vital capacity to tell us whether someone has a restriction. And we can't call it, we don't know whether it's due to an actual restrictive defect, because we can't quantify the residual volume. Now, if you perform spirometry in someone and the vital capacity is low, you say, okay, there's a restriction. That restriction may be due to an actual restrictive defect, or it could be very severe airway obstruction as well, right? Because, you know, if airways are narrow, you can't get the air in, you can't exhale that. Or it could be a poor effort as well. If someone doesn't perform the test properly, your vital capacity can be low. So if you find that your patient has a low vital capacity, you need to confirm, is this an actual restrictive defect? And for that, you need to measure the lung volumes. Okay, we need to quantify the residual volume, and then we need to measure what is called the total lung capacity. So there are many techniques that you can employ to measure lung volumes, where we are quantifying the residual volume. So the gold standard is whole body plethysmography, right? I can do a entire lecture on this, but I won't. I'll make it very simple. So basically, this places a patient inside a chamber with a constant volume, and you get them to breathe in and out. Right? And when they breathe in and out, they do various maneuvers. So I'm just going to go over here. I think you can hear me. We get them to breathe in and out normally. And then, after some time, we get them to exhale. So you can measure the expiratory reserve volume. And then, there's a measurement that is done, which gives us the functional residual capacity. So then we get them to breathe in deeply, which gives us the vital capacity. By doing various calculations, we can calculate the residual volume, and then you add that to the vital capacity, which gives you the total lung capacity. So this is the best way to measure lung volumes, right? But this is again a very expensive technique, and this equipment is expensive, but we have it in several places, right, in Sri Lanka at the moment. Thank you. Right. Now, if you don't have body plethysmography, you can use gases to measure lung volume. So what you do is you give a known volume of an inert gas, like helium, which will go and distribute in the lungs, in the alveoli, and then you send a known volume, then you let it distribute, and then you get them to exhale, and by the difference you can figure out what is the lung volume, right? So helium dilution is another method, and multiple breath inert gas washout is another method. There are some private hospitals here in Sri Lanka that employ this method. Central Chest Clinic has body plethysmography, and another private hospital has body plethysmography as well. Then in patients with cystic fibrosis, especially patients with asthma, sometimes COPD, it's very useful for us to know whether there is any inhomogeneity in the distribution of gases, right? Because even with asthma, even with COPD, tests like spirometry give abnormal results only when the disease is significantly advanced. But now the way forward is you need to detect these diseases early and see whether there are any problems early, so treatment can be given early. So using the multiple breath washout test, you can calculate a parameter called lung clearance index, which gives a very good idea of, like, let's say you have a patient, early, you're suspecting COPD very early, but spirometry is still normal, right? You can do these kind of tests, and you can figure out the ventilatory inhomogeneity in the lung and initiate the treatment early, right? So these tests are also very useful. Okay, so then you have a patient with restriction, and now you have diagnosed, okay, this is a restrictive defect. Now the next question is, where is the restriction? Of course, the history will tell you it might be a parenchymal problem, it might tell you it's a neuromuscular problem. Yes, the history and the other investigations will help, but to definitively find out and then to monitor your patient, you need to do a diffusing capacity test, right? So this is called the diffusing capacity for carbon monoxide. So very simply, you give a very small dose of carbon monoxide and you see how much of it is transferred into the blood, right? And that will give you a very good idea about oxygen transfer in the lungs. So this test is used. It will tell you several things. It will give you 3 parameters. One is the diffusing capacity. It will also quantify the alveolar volume that is available for oxygen transfer. And then there's another parameter called KCO, which will help you to decide, is the problem in the lung or outside the lung, right? Very simply, I'm just saying this. So the degree of severity is quantified as mild, moderate, and severe. And by looking at the parameters, you can figure out where is the problem, right? Now, I've given an example of 3 patients who have the similar DLCO values. So the cutoff, above 80% is normal, right? So here, 58%, this is abnormal. Now, we want to find out, now these are 3 different patients. So in the first patient, what you can see is, this alveolar volume is 74%, and generally, if you divide DLCO by VO, you get this KCO. So that is also reduced. So if you get someone with a low DLCO and a low KCO, that tells you that there is diffuse parenchymal damage and there is vascular involvement as well. If you see that the DLCO, VO are like proportionately reduced, that is telling you this person has a parenchymal problem, but it's in patchy areas, right? And the third one is a restriction can be an extraparenchymal restriction, and that you figure out when the diffusing capacity is low, but your KCO is very, very high. That means the patient has a restriction, but when you measure the alveolar volume, it's contracted so much that it can't be just the lung contraction. There must be something pressing from outside, right? So looking at the diffusing capacity, you can figure out a lot of information about your patient who has restriction, okay? Right, okay. So then the other cause of restriction is, you know, if you have paralysis of respiratory muscles or a myopathy or anything in your chest wall. So if it's a muscle problem, we have now facilities to measure respiratory muscle strength as well, right? You can measure the maximal inspiratory pressure and the maximal expiratory pressure, right? Okay. And And another simple way here, if you suspect that someone has a diaphragm defect, is you can get them to do a standing spirometry, measure the vital capacity, get them to lie down and measure the vital capacity again. And if you see more than a 20% drop, that tells you there is a diaphragm dysfunction. So that's a very simple way to do that. But if you're, and then if you want to quantify, like if you want to start ventilation and so on, then you do this test to figure out the muscle pressures. Okay, so all these tests that I'm talking about are available, right? Then, you know, now people do a lot of air travel, right? And people want to know, am I fit to travel, right? So one of the simplest things you can do, like respiratory system wise, is you can do a resting oxygen saturation, just a simple pulse oximetry, right? And according to the British Thoracic Society guidelines, if it is less than 92%, your patient will definitely get hypoxic during air travel. They cannot go without oxygen, right? But this is a better way, so that you are measuring pulse oximetry at room air. But you know that when we go in an aircraft and at normal cruising altitudes, it's as if we are breathing 15% oxygen. So what we want to know is, will my patient desaturate during air travel at that altitude, right? So one of the things you can do is something called the hypoxic inhalation challenge test, right? So there, what you do is you get a bag, fill it with a gas mixture, which will give the equivalent of 15% oxygen, right? So the patient inhales there, and then you're monitoring their pulse oximetry. You can even do arterial blood gases, and you measure their heart rate as well, right? And you can find out whether they desaturate. If they do desaturate, you can give oxygen and determine how much of oxygen that patient needs to carry when they are going in the airplane, right? So this normobaric hypoxic challenge test is now available in the private sector, but the best way is to do a hypobaric challenges, because it's not just the hypoxia that causes problems. Sometimes the low barometric pressure can cause problems. So the ideal is to put them into a chamber, and then it's as if you're inside the plane at that altitude and breathing low oxygen. So that's actually the best way. When I was looking for this image for the hypobaric, I just found this off the internet, and I was very happy to know that this is from the place that I trained, actually. It's from Brompton, because if you can see up there, there's that half moon thing there. It's a little thing, yeah, so I remember it was there. So I was really happy to get this off the internet anyway. Okay, so this is, we still don't have this setup, but we do have that, right, where you can assess whether your fitness to fly. And we are only predicting respiratory problems, not cardiac. We cannot prevent it if they have a cardiac arrest up there, right? So that's that. Okay, then of course there's also infant lung function test. We haven't moved there yet, but we're hoping to get there. But the things with infants is that, you know, little children are not going to follow instructions, and they're not going to stay in one place. So if you want to do lung function tests in infants, you have to sedate them, right? So that there is a bit of risk of sedation and anesthesia in that case. So you have to weigh the risks and benefits to see whether you really want to put the baby under sedation to do a lung function test. Okay, so that's like a brief overview of what we have. So what tests are available in Sri Lanka? Well, we have peak flowmetry, we have spirometry, we have DLCO, we have body plethysmography, impulse oscillometry, other techniques of forced oscillation. You can measure muscle pressures now. We have cardiopulmonary exercise testing and the walk tests. Pheno is available, right? And the normobaric hypoxic challenge test as well, right? Okay, so these are available in different places. If you're not sure, you can contact me and I will let you know where they are. I'm going to, from this point onwards, I'm going to talk about a bit more detail about spirometry, because spirometry is widespread in our country, right? Everyone, like people are using it now, right? So units are using, hospitals. The biggest challenge we have is that it's not done properly and it is not interpreted properly. More than the interpretation, the worst thing is that it is not done properly. So that is where the biggest challenge is. So that is why I think it's important to educate the interpreter to recognize that this is a good report, whether it should be reported, and how to interpret it, and when to order, and so on, right? So that's what I'm going to do. Okay. Right, so to talk about spirometry, before referral, right, I know this is difficult to read, but I have shared the material so you can go through. So there are contraindications to spirometry, right? And we call them relative contraindications. That is because the clinician can take a call whether the benefits of the test is advantageous over the risks. And you have to take the responsibility sending your patient. But spirometry is a maneuver where you have to take very deep breaths in and you do very dynamic maneuvers, right? Forceful, exertional breathing. So if there's any condition that will cause harm to your patient by forced breathing, you should not send the patient, right? That's very important. So things like aneurysms, recent cardiac events, pneumothorax, things like that. So the guidelines state that. The other thing is, if your patient is ill, don't send for lung function. Don't send for any lung function. Because when they are ill, their lung function will be abnormal, right? So lung function testing is done when they are free of infection, when they are physically fit enough to perform. Of course, if they have a chronic disease, they're not going to be physically fit to perform, but they should not be ill. That is the important thing. So at least 2 weeks after a respiratory or any acute illness, right? That's very important. And then they should be free of infection because you know this machine is going to be used repeatedly, right? So you should send someone who's acutely infective. So you can go, so you go through this. So if anyone has spirometry in their unit, I would advise have this list there, right? And check on it all the time before you send a patient for testing, right? Okay. So now, now you decided your patient can undergo the spirometry. Now, how are you going to prepare the patient? Now, they don't need to fast, right? They don't need to fast. I have had patients who have been kept fasting from 6 o'clock the previous night. When they come to the machine, they can't even stand up, let alone perform the test, right? No need to fast, but they shouldn't take a large meal before testing, because you know that when we eat, we switch into parasympathetic mode, which kind of it causes bronchoconstriction, right? So we don't want that. So we say no large meal 2 hours before. Better to avoid tea and coffee, right? Because they are bronchodilators, and like things like cola, sodas, like they also cause bronchodilation. So avoid those. No vigorous exercise 30 minutes before testing. So even if they come huffing and puffing, we keep them for 30 minutes and then let them settle down. And then if you want a bronchodilator reversibility test, because why you send is you want to see, okay, is there airway obstruction and is there a response to bronchodilators? So if they're already on bronchodilators, you need to stop the bronchodilators. So there are guidelines, like short-acting can be used up to about 4 hours before the test. Long-acting, depending on the type, you omit for either 12, 24, or even 48 hours. Oral drugs, generally 2 to 3 hours, right? Now, if your patient can't wait without the long-acting bronchodilator, you can take them off the long-acting the previous day and keep them on the short-acting until the morning they come for the test. Okay, so that's also important. Sometimes patients are taken off bronchodilators and they come with severe, wheezing and whatever, and then we can't test. So this preparation is also very important. Okay. Then the next thing that you need to know is, please, when you're sending, I'm not promoting any unit or anything, it's just that please find out about the unit that you're sending your patient to, whether they are actually generating good lung function results, because otherwise it's a waste of time for the patient also. Some units, they don't follow the proper techniques. And also make sure that wherever you're sending, they are using these disposable antibacterial viral filters. Some places use paper mouthpieces, which is not hygienic at all, because you're blowing in and out to the machine, you're going to infect your patient, right? So these things are important. Okay, so what does spirometry tell us, right? So we'll go one by one. The main question you want to know is lung function normal, or is there an obstruction or a restriction? Now, when you perform spirometry, when you send to the unit, the first thing that is performed is what is called a slow spirometry, right? Because if a patient has airway obstruction and you put them onto a spirometer and you ask them to forcefully exhale, what is going to happen is, in some patients, like patients with emphysema, because of the floppy airways, there is a tendency to collapse. And then you can't get any air out of them. So we need the vital capacity, right? So a very good way to get that vital capacity is to do what is called a slow spirometry. So when the patient comes, you get them to breathe slowly in and slowly exhale until their lungs completely empty. So you get the vital capacity value and you keep it aside. Because the next maneuver is to find out, does someone have airway obstruction, right? So for that, you perform what is called a forced spirometry maneuver. So there, the patient is asked to take a deep breath in and then blast out the air, keep exhaling for as long as they can, and deep breath in. Okay, let me just do one, I'll just show. So the maneuver is they have to go in and then they go back again. Right, so that is the proper technique, and the patient has to do that, and the technicians have to do that and show the patient, otherwise they are not going to do it, right? So once you do that, I have a bit of asthma and I got a little bit of bronchitis. Anyway, right, so once you do that, you generate these flow volume loops. So we want to see, does your patient have obstruction or restriction? So airway obstruction, now you are familiar with the flow volume loop, right? So on the y-axis you have flow, on the x-axis you have volume. The bottom part is inspiration, and the top part is expiration. So you know that in airway obstruction, it's mostly exhalation that's affected, right? So what you see in the flow volume loop is you see that scooping, right? You see that scoop. So that tells you, okay, your patient has airway obstruction. If it's restriction, what you see is that this curve becomes narrow. So you get a very tall, narrow curve, right? That tells you there is a restriction. So by looking at the graph, you get that idea. Then you can also look at what is called the volume time graph, right? And that is my attempt to draw a straight line, I'm sorry, right? But anyway, the black line is a normal one. This is showing the exhalation. So the patient has taken the breath in. When they exhale, I have mic here as well. So when the patient exhales, you know, the air gets blasted out. So, you know, when you exhale very forcefully, when I exhaled, you heard the sound at the beginning, right? And then you didn't hear at the end. Because at the beginning, the flow rate is very fast. The flow is very fast. So actually, in an adult and even in a child, 80% of that air is actually exhaled in the first second, right? But if you have airway obstruction, like in the red one, in the first second, that amount is less. Right? So that is, so when we want to diagnose airway obstruction, we look at the parameter where we divide FEV1 by the vital capacity, right? And 80% is normal. But in someone with airway obstruction, it is less than 80%. So when you push out the air, it goes and goes and goes and plateaus. So that's the maximal exhale volume. That is your vital capacity. So someone with restriction, the green line, you can see that the vital capacity has reduced. So patients with pure obstruction and mild to moderate obstruction, they might be able to achieve their vital capacity, but it will take some more time for them, right? But people with restriction, definitely within that time, they can't exhale, right? So this is, looking at this also, you can diagnose whether your patient has obstruction or restriction, right? Then when you take restriction, I told you there's narrowing of the loop, right? Now, if someone has interstitial lung disease, we see a very tall, narrow loop, right? We call it the witch's hat appearance, right? If it is due to a chest wall defect, generally we see that the peak flow, which is the top part there, moves down. But still you get a fairly pointed peak, right? Now, sometimes patients don't perform the test well. In that case, what will happen is, if you can see this corner diagram, can you see this is not a tall peak, it's like blunted, right? So when the report comes to you, look at the flow volume loop. If you see that the peak flow is like that, that means it's not been done properly, and you have to, right? So that's very important that you learn to recognize the flow volume loops, right? So that is how you recognize use in the graphs. Then you have to look at the values. So obstructive is if your FEV1 FVC ratio is lower than normal. Restriction is if your vital capacity is lower than normal. So what is normal? Now, we have got used to looking at, now lung function is when you perform, you get a value for the patient. Right, like if you perform vital capacity 2.5, my vital capacity is 2.5 liters. But it doesn't tell us anything. What is important in lung function is you need to know, is it within the normal level? So for that, what we do commonly is we divide that value by the predicted value for that person. So that is why when you come for lung function, we measure the height, which is the best predictor. We measure we get their age, and we enter whether their gender and also their ethnicity as well. And using those parameters, the machine will generate a value for that patient. So what the machine does is it divides the measured value by the predicted value, multiplies by 100. So if it is above 80%, it is normal. But if it is less than 80%, it can be abnormal. Why I say can be is now it is moving towards not using percentage of predicted, but using what is called the lower limit of normal. You know, like when you put values together, you get the normal distribution. So the lower limit of normal is the less than the 5%, right? The 5% on this side, and the upper limit is above 95%. And the reason is because predicted values are calculated using, it will differ according to the ethnicity, according to various factors. And the machines, the formulae are not geared for Sri Lanka, for our population. So the machines will give values for Western populations. So when, I don't know whether if you have experience with spirometry, if you send, most of the reports come back as restriction. That is because they are dividing by a vital capacity generated for a population that is, who have larger lungs than ours. So now what they have done is, there is something called the Global Lung Index, where they have collected lung function, like people have taken healthy volunteers from different countries and measured their lung function, and they have given that to one place, which has now generated reference norms that can be used worldwide. So I said, when you're sending your patient to a unit, or if you have your own unit, just enable the reference equation GLI, because that's what the guidelines now say. The reference equations you're supposed to use are the GLI to divide your patient's actual values, okay? Right, so that is now available in the new equipment that is coming, right? But the goal criteria for COPD says that someone is diagnosed as airway obstruction if they have less than 70%, right, the ratio. And in children and young adults, you can consider 80% as the cutoff. If someone is elderly, above 65, then you use 70% as the cutoff, okay? Right. Then what about restriction? How do we diagnose someone with restriction? Their vital capacity is less than the lower limit or less than 80%, right? So spirometry can tell you whether your patient has obstruction or restriction, right? So these are some other ways. So one thing that I spoke to you about, is using percentage predicted, right? That is what most machines give. Patient's actual value divided by predicted. So anything between 80 to 120% is normal. Less than 80 is low. Above 120%, in some cases, that is a problem. If you take the total lung capacity, more than 120% means hyperinflation. But most of the time, that's okay. But now they are saying to move to lower limit of normal. So if you look at the chest clinic reports and some hospitals, they have enabled lower limit and upper limit. So you look at the value relative to this. In some reports, we have also put the Z scores as well, because that is a better way. In some reports, you will see it in red and green dots, right? So looking at that, you can find out whether it's normal. So between -1 to +1 is normal, and so on. Then there is even better way, where some reports give standard residuals. So you look at your value and see where it is relative to these values, right? So there are different ways where we classify normality. It is easy if someone is grossly abnormal. These other things are important when they are borderline, because that's when you're going to say whether they are normal or abnormal, right? So that's why it's important to have as many reference ranges as possible. Okay, right. So just showing you a report, right? And so when the report comes to you, the first thing you need to do is look at the graphs. So you can see there is, of course, this doesn't show the inspiration, but you have a flow volume loop and you have the volume time group. And just to show you that different reports give different things. So if you look at this, they have even given the Z score. So by just looking at that, you can see closer to 0 is normal. When it shifts here and there, you know there is some abnormality there. Then you get the measured value. You look at the lower limit. For example, FEV1 measured 3.16 is more than 2 point, the lower limit. So you are fairly confident it is normal. Can you see that? If you look at FVC, 4.70 and lower limit is 2.98. So you can think, okay, that's normal. So you can either use lower limits, you can use percentage predicted, and you can use Z scores. So different ways in finding out whether the lung function is normal or not, right? Okay. Yeah, so, right. I will come to this later on, right, okay. So then once you have diagnosed your obstruction and restriction, next thing you want to know is what is the severity, right? So if it's obstruction, you can use, looking at the FEV1 percentage, you can classify mild, moderate, severe. Same with vital capacity as well, right? So they are in the guidelines. It's always helpful to have these guidelines pasted on your desk because you can't remember these things. You quickly look at it and then you can classify. Right. Then sometimes when you send your patient who has airway obstruction, if it's very early airway obstruction, FEV1 FVC ratio can be normal, right? So then what do? So then you look at what are called the mid-expiratory or maximal expiratory flow rates, right? So this is again the flow volume loop. You can see bottom is inspiration, that is exhalation, right? When they blast out the air, the top flow rate is the peak flow rate. And these ones, can you see in the reports, you would have seen these FEF, or you can call them FEFs, or you can call them MEFs as well, right? So these give you the mid-expiratory flow, right? Now, there is FEF 25, 50, and 75. If you are looking at FEF values, 25 is up there, 75 is down here. If your report is giving MEF values, MEF 25 is here, 75 is up there. Just remember that, right? So peak flow and FEF or FEF 25 or MEF 75, those two tell us more about upper airways, right? These ones, FEF 50 is the best indication for mid flow, and this part is the lower airways, right? Okay, and remember, when someone is performing spirometry, you know the last bit is very difficult to exhale. So in sometimes your report, only this value can be abnormal. Do not diagnose airway obstruction in that, right? Because it's more likely it was a technical thing. Isolated MEF 25 abnormalities is very rarely airway obstruction, okay? Right. So if someone has airway obstruction, these are the things that you see. You will see peak flow has reduced, you get these flow rates have reduced, like a scooping like that. So that is what you see when you have like the mid airflow obstruction, okay. Right, so looking at this now, can anyone tell me what's the first thing that comes to your mind, obstructive or restrictive? Yes? Obstructive or restrictive? Yeah, obstructive, isn't it? What has happened? The expiratory loop has, it's very, very narrow, right? So this kind of pattern is seen in patients with emphysema because you get them to forcefully exhale. Remember, I told you there can be sudden collapse of the airways. So what happens is they forcefully exhale, airways collapse. After that, the air is coming very slowly, right? So this shows air trapping, and with this sometimes you find a very low vital capacity because they can't push the air out, right? So this is called dynamic compression of the airways, a common pattern that you see in patients with emphysema, right? Just to show you different ways, right? Then, so that is normal traditional airway obstruction, but you know that patients also have upper airway obstruction, like fixed, variable intrathoracic or variable extrathoracic, right? And spirometry is the only way you can actually see whether this is there, right? So if someone has upper airway obstruction, the traditional flow volume loop changes, right? If they have a fixed airway obstruction, you will find that you get a pattern like this here. Can you see here what has happened? The blue one is the normal, right? In fixed airway obstruction, it's got blunted. So airflow is blunted during expiration, like inhalation and exhalation, right? Sometimes they can have a variable intrathoracic. Then the expiratory loop is blunted. If it's variable extrathoracic, the inspiratory loop is blunted. So you can only see this when they are performed. Your spirometry loops can come like this. You might think, they haven't taken a good breath in, or they haven't done the exhalation properly, but sometimes they are actually doing it really well, but you get this pattern. That's because they have this. So if you see anything like this and you're suspecting an upper airway obstruction in your patient, then you have to look at the flow volume loop and you calculate something called the MP index, right? Where you can just take your FEV1 and divide it by the peak flow, and then if it is more than 8, that tells you there's a upper airway obstruction, right? That is the definitive way of diagnosing it. There's also another parameter which is, in your flow volume loop. Now, if you take the flow volume loop, somewhere here is where you have exhaled 50% of your exhalation. Here is 50% of your inhalation, right? So you can divide that by this to see whether they are disproportionately changed, right? So in a normal person, there is a certain value, but so if it is like this, if you divide this by this, you are going to get a large value, right? If you divide this by this, it's going to be a very small value, right? And if you divide this by this, you're going to get a value of 1, right? So looking at those parameters, you can diagnose, does your patient have an upper airway obstruction? Like, okay, variable extrathoracic is like having like a goit, some mass up here, right? Or some vocal cord palsy or something like that. Variable intrathoracic is there's an intrathoracic mass that is compressing, right? Or fixed upper airway is like a tracheal stenosis or a large goiter compressing the airway, so airflow is obstructed. So patients like that, you can find out using spirometry, right? Okay, so then the next thing in spirometry is, does my patient who was diagnosed with the airway obstruction, are they responsive to inhalers, basically, right? So we do what is called a bronchodilator reversibility test. So how you do that is, your patient, you do the spirometry, then you give them a bronchodilator. So the guidelines say you can give a short-acting bronchodilator, you can use beta-2 agonists, then you give 400 micrograms for an adult, 200 micrograms for a child. It has to be given through a spacer and a metered dose pressurized inhaler, and then you give that, wait for 15 minutes, and then you repeat the spirometry. Right now there, it's important that the proper technique of taking in the inhaler is done. You can't just put 4 puffs into the mouth, like, the proper inhaler technique has to be done. Now, these inhalers come about 100 micrograms, right? So you have to take it out, shake it, and then put it back for each attempt. So that's important. So you do that, and if it's anticholinergics, you can wait for about 30 minutes. If you're using like a beta-2 agonist, you wait for 15 minutes, and you repeat the spirometry. So what you want to see is, has the FEV1 improved from the baseline, right? Now, if any of us were given a bronchodilator, anyway, it would improve. So how much is normal? So what they say is, generally, if you get a change of more than 10% in FEV1, then it is significant. But to say very, very significant, the American Thoracic Society criteria says you have to have 12% plus 200 milliliter improvement, right? You can't just have a percentage. The FEV1 volume has to increase by 200 milliliters. But if you take children, they have low lung volumes, so you will not probably see the volume change. So then for children, you say 12% is the diagnostic cutoff. If you are looking at improvement in mid-expiratory flows, 30% is the cutoff. If you are looking at peak flow, 20% is the cutoff. So what you are seeing is, you measure the value, You give a bronchodilator and you see whether these percentage improvements are there, right? Asthmatics can improve, to diagnose asthma definitively, it is 15% plus 400 milliliter improvement, right? Because that is there. Now remember, if someone has a respiratory tract infection or they have had a recent viral flu or anything, if you do a bronchodilator reversibility test, it's going to be positive. Because during infections, your airways become reactive. So that doesn't mean it's, and that's why I said you have to wait for at least 2 weeks after an acute infection if you want to do a bronchodilator reversibility, right? So that's important. Also remember, if your patient has very low lung volumes, right? It's a short patient with very low lung volumes, you might not see that 200 milliliter improvement, right? So even in adults, sometimes you can just consider the percentage improvement, right? So that's about the bronchodilator reversibility, right? Right, now, lung function testing, it is very important not to go straight for the values when you're interpreting. You have to look at the graphs, and I'll show you why. And especially in bronchodilator reversibility testing, it's very important you look at the graph and make sure that the technique has been done properly. Right? Now, look at the first graph. Right? If you look at that, the red one is pre-bronchodilator, blue is post-bronchodilator. You can see clearly there's a good improvement. If you look at the flow volume loop and the volume time graph, you can see they are nicely shaped graphs, right? Look at the second one. What do you see in the red one? Can you see? It's not a very good technique, the pre-bronchodilator, but post is good. So there now, again, if you look at the values in both these reports, both of them will give you significant bronchodilator reversibility. But first one, we are sure it is the action of the bronchodilator. Second one, it may be effort improvement as well. Right? So that is why you have to make sure that when you're doing a bronchodilator, pre and post efforts are equal. So I think by now you understand how important it is that whoever performs these lung function tests knows what they are doing and does it correctly. Because otherwise the report you are getting is not a true representation of your patient. Right? That is why it's very important. Okay, so again just showing you another actual report where you can see improvement, bronchodilator reversibility, right? Okay. And if you look at the values up there, look at FEV1 measured is 1.2 and post is 1.63. So obviously there is about 400 milliliter improvement and the percentage change is also 36%, right? So this is significant bronchodilator reversibility. The graphs are telling you that, then you confirm by looking at the values. Okay. Right. So now you know the theory behind it. Very quickly, I'm going to take you through. Now imagine you have sent your patient for lung function testing. You have ruled out contraindications. You have figured out they need a lung function test. So you have sent your patient. And now the patient comes back with the report. Right? Now you have to interpret it. Now the first thing you want to find out, is this test performed well? Right? Should I interpret it or should I just stretch it up and put it in the dustbin? Okay, that has to be done. You have to report it again. You have to get it done again. Right. So there are three things you look at. Are the reports acceptable and reproducible? So one thing is, have they exhaled for at least more than 3 seconds? Second thing is, are the curves smooth with no artifacts? Third thing is, are they reproducible? I'll just show you graphs, okay? And then you can have a look. Right, number one. Most of the time we see reports like this. So, I don't know. Or you see flow volume loops with that's not a good thing. If you see, this person hasn't even exhaled for 1 second. How are you going to calculate FEV1 over FVC? That value will be normal, because first second. Now, in this, FEV1 is value, FVC is this value. So it might come as the ratio is normal, but it's not normal because it's a bad report, right? So if you see anything like this, straight away into the dustbin, right? You need to have a very good curve. You need to have a volume time graph like that. And your flow volume loops have to be smooth like this, right? Now I talked about artifacts. That is a normal flow volume loop. The second one is where anything that can go wrong has gone wrong, right? So like a slow start, can you see a slow rise, a flat peak, a cough has interrupted, and there's no end of test also. Sometimes when patients are exhaling, you get this glottis closure, and then you get a drop like that. Then you are not capturing some of the air. So if you see anything like, okay, first one is good, second one, what's the problem? The peak flow is not very sharp, right? So that means you will not get a proper peak flow. Second, in C, what do you see there? There's a cough. Can you see there's an artifact here? Can you see that? So that will affect your final vital capacity. Then here, there's a sudden drop. In the third one, can you see there's an air leak? See, the flow volume loop has to be closed, right? Can you see in that, the third one, here's, some of the air has not gone into the machine, it's gone out, right? So all these things are important, right? You must make sure you have a very nice closed loop before you interpret, right? And then sometimes you get a very slow start like that. That's because they start down. You saw how I did the test, right? I took a deep breath and I blasted out immediately. Some patients take their time. Then you can't calculate the FEV1. So things like that, right? Okay, so you have to look at those to make sure there are no artifacts and you're happy with the graphs. Then even before you look at the values, you look at the graphs. Why do we look? To see whether it's normal or obstructive or restrictive. For example, yeah, it's your turn now. Okay, so I'm going to ask you, first thing that you think of when you say this, normal, obstructive, restrictive. Yes, yes? What do you think? What's the first thing that strikes you here? It's a very narrow loop, right? So the first thing that comes to your mind is restriction. You're correct. This one? Obstruction. Very good. Right. Next one? Again, obstruction. Right. Which is more severe? One on the left. Why? Because peak flow has come down. You can see severe air trapping there, right? Okay, so we still haven't looked at the values, but we have come to a fairly good diagnosis, right? Okay, good. Right, this one? What do you think looking at the flow volume loop? Is there something that really strikes you there? Okay, anyone? Yes? Okay, now flow volume loop, what is the bottom part? Inhalation, top part is exhalation, right? So let's look at the exhalation, peak flow, okay? Yes, because you can see the reference is there, peak flow is good, right? There's a slight scooping though, right? Okay. What about this? It's low, right? So this could be low because somebody hasn't taken a good effort. Now when the reports come to you, sometimes you see one like this, but the others are okay. That means they have improved with each effort. But here you can see consistently, this person's peak, this is low. So this could be an upper airway obstruction, right? And if it's compatible with your history, then you look at the parameters, okay? Right. So actually it looks like this one, right? Like a variable extrathoracic airway obstruction, right? All right. So the next thing is, so now you look at the flow volume loop. Then you want to see, is the lung function reproducible? Meaning now, when a patient comes to do a lung function, we don't only do it once. Right, lung function, patient technique is difficult. So patients improve with each effort. So the guidelines say at least 3, right? And they have to be reproducible. Like so all of them are the same. But you know, there are some patients like this. First maneuver is okay, second is even worse, and third is really bad. Or the other way. First is good, second is better, third is even better, fourth is even better, fifth is even better. So you have to keep on doing. But how long do you do that? Guidelines say only 8 times, or if the patient feels dizzy or something, you have to stop. But if you have someone who's not reproducible, we tell the technicians to send all the efforts. Because when you get a report, you get single values, right? But that is because the machine has selected the highest values of each parameter and given it to you. In lung function, we look at the highest values. But if someone is like this and different maneuvers are different, we ask them to send all the trials. So you are allowed to pick the highest vital capacity, right? You are allowed to pick the best FEV1 and use those parameters to calculate your parameters, right? So you can pick and choose, always go for the highest value. It doesn't have to be in the same maneuver, right? Now in the first trial, you can see FEV1 is the highest, but FVC is low. The FVC is highest in the third trial, okay? So without interpreting the first trial, you can pick FEV1 from this and FVC from that and then calculate your value. That is the proper way to do it, okay? Right. So once you have done all this, mind you, we still haven't looked at the values. You have already come to a diagnosis now. Now you're going to confirm your diagnosis, right? So what we do is we look at the parameters. Now, the thing with lung function reports is when you see a report, you want to run away, isn't it? Because it looks so complicated, so many parameters, right? Personally, I feel ECG is more hard for me. I like lung function because it's very simple. Even though it looks so complicated and different units give different parameters, there are three things to understand. One is there will be one column giving the predicted. Or instead of the predicted, they might give you the Z score or the lower limit or whatever. So that is your reference. The second or the middle column will be the actual value of the patient. And then you will get either the percentage predicted or you look at, like if you look in this one, it's the upper limit and the lower limit. So you compare this value with those, right? Very simple. Now you have so many parameters, look at that. Now how do you know what to look at, right? Very simply, these are the ones that you need. You want to diagnose airway obstruction, you look at FEV1 over FVC. Or it can be FEV1 divided by the slow vital capacity as well. Because in some, if you have done a slow and a forced, you can use the larger value for this ratio. Then if you want to find out someone has a restriction, you use the vital capacity. Very simple. Those two parameters will tell you, is there obstruction, is there restriction. Then if you want to grade your obstruction, you look at the FEV1 percentage. If you want to see whether it's upper airway obstruction, you look at the peak flow value. If you want to see whether it's more lower airway, you look at the FEF 25, 75 values. Right? That's all you need to do. So, a little more thing you need to remember is when you're looking for that FEV1, FVC value, you have to look in the measured column. Right? Now, if you are used to interpreting using percentage predicted, now there are two columns, the actual and percentage predicted. The FEV1, FVC ratio you take from the actual measured value. So in this case, it is 95. Can you see in this one? FEV1, FVC is 95. You take it from that. Everything else you take from this. Is that clear, right? So if you look at that report, FEV1 over FVC is 95. That is way above 80%, no, so that there is no airway obstruction. If you want to look at the restriction, FVC, you look at 16% over there. Can you see percentage predicted? That value. And that tells you there is very severe restriction. It's just 16%, right? So remember that when you're interpreting, you don't look at the percentage predicted value when you're looking at the ratio. Okay. Right. So that brings me to the end. So I'm going to leave you with a little algorithm which you can keep. This is regarding spirometry, right? So, and this is the order, the rational order to go if you want to interpret, right? So number one is, oh, it already went. Right, okay. So when you get your report, look at the graphs. If you're happy with the graphs, come to a tentative diagnosis looking at the graphs. Then look at the ratio. If your ratio is normal, look at the vital capacity. And if that is also normal, there is no airway obstruction, there is no restriction. This is a normal study. Okay? In these patients, if you are still suspecting, they are the ones that you are going to send for airway resistance measurements or bronchoprovocation or challenge tests, right? If you are suspecting still. Then if your ratio is, if your vital capacity is low, that is a restriction. What do you do if you see a restriction? What is the next test you will send for? The lung volumes. You have to confirm the restriction, right? Now, if your ratio is low, it is always airway obstruction, right? And we said that elderly people, 70% is the cutoff, young adults and children, 80% is the cutoff. Or you can look at the lower limits. Then in your obstructed patient, if the vital capacity is normal, it is a pure obstruction, right? But if your vital capacity is low, then it is a mixed obstruction, right? And anyone with an obstruction, you're going to do a bronchodilator reversibility test, right? So if you follow this simple algorithm, you can't go wrong, right? So the key messages are, know your patient. If you want to send for a lung function test, you have a wide array of lung function tests to send to, not just pyro, right? You can pick and choose. There's so many right now. So decide which one. If it is spirometry, rule out the contraindications, prepare your patient, send to a good unit who are doing good technical spirometry, right? Following the proper techniques. When you get the report, look at the graphs to figure out, is this report a good report? And if you're happy only, then look at the values and interpret. And then you can send for further lung function testing. Okay, so that's the end of my talk, and I can take a few questions, I think.
Madam, I was wondering whether we can use the normal or increased FEV1 by FVC ratio in addition to the reduced FVC to diagnose restrictive disease.
You mean the ratio?
Yes.
No, so again, diagnosis of a restrictive defect is by looking at the total lung capacity, right? You have to have a total lung capacity value to say it is a restrictive defect. Spirometry will tell you whether it is restricted or not, the restriction. So it will tell you vital capacity is low. But again, definitively to say that there is a restriction, the vital capacity has to be low. But what you will notice is that when the vital capacity reduces, proportionately with that the FEV1 reduces. So your ratio will normalize, right? So in an obstructive defect, FEV1 FVC ratio is low because FEV1 reduction is more than the vital capacity reduction. But in a restricted patient, the main problem is vital capacity reduces, automatically with that FEV1 reduces, but it's a proportionate reduction. So you can't use the ratio to diagnose restriction. In spirometry, restriction is diagnosed by vital capacity. It is confirmed by total lung capacity. If you don't have a facility to do lung volumes, if your vital capacity has gone below 60%, you can be pretty sure that there is an actual restrictive defect. The difficulty is above, between 70 to 80 when you're very not sure. So if then if you have like a percentage predicted around 70 and you're not sure, you can look at the Z scores. Or you can look at the other lower limits and things to help you in your diagnosis. It's a borderline that's the problem.
Thank you, madam.
Right.
I have another question.
Yes.
Because we are as clinician, with the busy schedules,
Yes.
is there anything that without the equipment in the
Yes.
bedside diagnosis for any lung function as well?
In the sense that you need to diagnose airway obstruction and so on. Well, again, as I said, peak flow metry, you can't diagnose what it is, but you can use it in an already diagnosed patient to assess. I mean, if you have a patient who's already diagnosed and is in the ward or at home and you want to see whether they are recovering or not, they can use a peak flow meter to daily look at their peak flow rate. That can be done. Then tests like, pulse oximetry is also a lung function test. So, you can do resting level oximetry if it is a condition we are looking at desaturation. But if you want to definitively diagnose airway obstruction, now they have said spirometry is the gold standard. You have to go for lung functions with that. So it will either have to be a clinical judgment and which will be solidified by sending for these lung function tests. Okay, right.
Any other questions from the audience?
Yes, Asila.
At the faculty, we have a newly established lung function assessment unit. So you can,
Yeah.
you know,
The
coordinate-
advertisement part, ne? Yes,
Yeah,
right.
the advertisement part, sorry. No, actually it's very important, and you all can communicate with her also,
Yeah.
right? Because she has done a wonderful lecture, right? So that you all can ask questions also and
Yeah.
learn on the go.
Yeah, so
Thank
in
you.
the faculty, in the Department of Physiology, we have spirometry, we can do standing supine. We also have a FitMate, which gives you the, I didn't talk about VO2 max, you know, the oxygen consumption levels. But we are also establishing a respiratory center, and we are getting the full lung function very soon. So all those are there. So if you need any details about lung function testing, where to go, who to send, which test to do, we are very welcome to do that. Another thing, thank you for reminding me, Asel. So we are having actually a lung function workshop next week for technicians and technologists who are performing. So already it's actually now closed, but I will be conducting biannual ones from next year, right, early in the year and later. So if you have technicians, technologists that you would like to send for training, you can send. We are also planning to do more intensive interpretation workshops for medical officers. So that, you know, like now I just spoke about spirometry, but there's so much more that you really need to know. Then do different kinds of workshops for other techniques as well. So when those come, we will send to the college, and maybe you can distribute it around. We'll be doing that from next year onwards. Okay, thank you.
Thank you.
Any other questions from the audience? Yes, thank you very much, Professor Lakmali Amarasi. You have given us a very interesting and interactive session, really. Really, you have taken me to my era of the physiology as well. So thanks a lot for coming and giving us this we appreciate on behalf of the Ceylon College of Family Physicians. Thank you again.
Thank you.
I call upon the two chairpersons of this session to give a kind token of appreciation to the speaker. So we have had a very informative first presentation. We will be breaking off for tea now. There are refreshments arranged out in the lobby for you. Please enjoy them, and to make sure that you will be back in your seats by about 10:30 to start the second session for the morning.